Welcome everybody. It's great to see so many people joining. I know we are expecting quite a good attendance today. My name's Laura Harries and I work in the CLEAR team, and I'm going to be hosting today's webinar where we're going to discuss our chronic kidney disease transformation project. This session forms part of the wider CLEAR Impact webinar series, which essentially brings together those people involved in delivering our transformation projects to share their learning and the impact of their work. I'm just going to remind everybody that the session is being recorded so that we can share it afterwards on our website and across our networks. For that purpose, if you can keep yourselves on mute whilst the presenters are working through their slides, that would be great. If you do have any questions, we would recommend that you put them in the chat. We'll do our best to answer them before the end of the session. If there's any that we don't get around to answering today, I'm happy to respond directly to whoever asks a question via email. So today's webinar is going to focus on the CLEAR CKD project, which is a piece of work that was funded through sponsorship with Boehringer Ingelheim. And I'm delighted to be joined by a number of wonderful speakers. So Maria, if you can move the slide along for me, I'll just introduce who we've got on the call with us today. So I'm accompanied by Laura Breach, who's another managing consultant in the CLEAR team. And Laura is going to kick us off today with an introduction to the National CLEAR programme and our 4-stage methodology. We also have Smita Sinha on the call, who is the NHSC National Clinical Director for Renal Medicine. Smita worked with us as part of our specialist reference group at the beginning of the programme, and she's kindly agreed to come along today to do some scene setting around CKD and also to talk through why it's a national priority. We then have Yeti Viji, who is a lead nurse and was the clinical lead for Breckland Alliance PCN on this programme. Michael Oliver, a general practitioner who was the clinical lead for Garstang PCN on the programme. And both Yeti and Mike are going to talk through their experiences of working on this CKD piece of work and highlight a little bit about their PCNs, what some of the challenges were, what their starting point was on the programme, and then where they've ended up. And although both of them have just started to implement their new models of care, they've already seen some good sort of early insights, which they're going to give us an overview of today. We are also hoping to be joined by Beng So, who is a CKD ICB lead for Lancashire and South Cumbria and consultant nephrologist. And Beng is going to give us a secondary care perspective for this piece of work. And then last but by no means least, we have Shanika on the call, who has been our project manager since the outset and has kept us all in line. And Shanika is going to facilitate our panel discussion today towards the end of the session. So that's all from me for the moment. I'm going to hand over to Laura, who's going to kick us off with the introduction to CLEAR.
Hello, everyone. Great to see so many of you here today. I'm just going to talk to the National CLEAR programme briefly. If you could move the slide along, Maria, please. So the National CLEAR programme was developed in partnership with Health Education England, and it was designed by a group of consultants and some data analysts and scientists who felt that transformation with the NHS could be better if it was clinically driven. And what came from that was a methodology, which was named CLEAR, that was designed to place clinicians at the heart of transformation, with that recognition that there are executive national drivers, but that clinicians often know what the changes need to be on the ground. And the CLEAR programme developed from that and is hosted and developed in partnership with East Lancs NHS Trust. Next slide, please. We have several consultancy offers that we provide, but they all follow the CLEAR approach, which is a 4-stage process. And the first stage in that process is clinical engagement. And this is where we speak really broadly with anyone who is key in the delivery of the pathway that we're looking at. And that can be from admin staff, nurses, GPs, consultants on the front line, but it can also be broader stakeholders, such as engagement with patients, with national colleagues, or with voluntary sector organisations. And we do that to gain insight into what the key issues are and truly understand what needs to be addressed within the pathway. We then move into the data interrogation phase, and this is where we will take data from the sites that we're working with alongside national data sets that are available, and we triangulate that with our clinical engagement themes. And that allows us to have a really clear picture from both qualitative and quantitative data of where the issues lie and where the impacts might be able to be seen. We then take that forward into the innovation stage. So with that visibility across the issues and challenges, we can start to develop innovations that are clinically driven to address those issues, and we can start to work out what the workforce modelling needs to look like for that, and also what the impacts we're expecting to see are. From that, we'll make recommendations and provide support to develop an implementation plan so that sites can take actionable steps to move forward with the work that they've designed. Next slide, please. And we've provided support to NHS organisations across England. You can see from the map there that we've had really good coverage across England and across a number of projects and specialties. Over 90 CLEAR projects have been completed or are underway, aligned with NHS priority areas. And on that note, I will hand over to Smita, who will set a bit of context for the CKD work that we've been doing. Over to you, Smita.
Thank you so much. Thank you for inviting me to speak today. I will try and set the scene, but I think as you've already heard, the priority is on the work that happens in front of the patient, so at grassroots level. Next slide. So I'll start with a global view first. Next slide. CKD is increasing in recognition globally. This is partly because of data that was published a few years ago now, which shows that CKD is rising up the ranks of premature death. So in 2016, it was way down there, but if you look at predictions for 2040, it's expected to be the 5th leading cause of premature mortality. So that's raised its profile globally, and that's been recognised by the World Health Organization. If you can just do the next transition, who recognised that CKD was a major non-communicable disease. So the ones that they previously had were things like cardiovascular disease, respiratory, cancer, neurological diseases and diabetes. So kidney disease was missing, but that was recognised and formally ratified by the United Nations at the beginning of this year, having been put forward by the World Health Organization last year. So we now have kidney disease recognised globally, but what does that mean for us in the UK? Next slide, please. Many of you will be familiar with this chart that is from the UK Renal Registry, and what you can see is a straight line upwards, so regardless of which devolved nation you work in or reside in. And this is expected to continue, if not accelerate, given our ageing population and increasing comorbidities that we see. So there are many people living with multiple long-term conditions that puts them at significant risk of developing end-stage kidney disease. Next slide. So we know that this is happening, and in the kidney world, we've certainly focused on kidney disease, but there are wider conversations happening about the NHS as a whole. And I suspect most of you will already have seen this, but this is the 10-year health plan that was published last year. And this is from the UK government, which is talking about 3 radical shifts. So moving care from hospital to community, closer to home, moving towards a more digital world, given the wider opportunities out there, but also a greater focus on prevention. And there are a couple of things, there's a lot in that document, but there are a couple of things that stand out. So there is also a health mission that sets an ambition to reduce premature mortality from heart disease and stroke by 25%, all within a decade. But there was also a commitment to these things called modern service frameworks, and they're there to give you the how, the what do we need to do to meet the ambitions of the 10-year health plan. So there isn't a kidney disease modern service framework, but unsurprisingly, given that health mission, there is going to be a modern service framework for cardiovascular disease. So the next slide highlights where kidney disease might sit in that. We all know about the common risk factors for cardiovascular death, hypertension, hyperlipidemia, diabetes, but CKD has been overlooked. And the data on this slide highlights that it contributes to a significant amount of cardiovascular deaths. So if the government wants to meet its ambitions for England, then it can't do it without CKD, which means it can't do it without detecting this important risk factor and treating. Next slide. So there have been some changes that have happened in the GP contract this year, which may help us detect people with CKD earlier or encourage earlier detection. So there's a new diabetes QOF indicator. The GPs in the group probably already know this, so apologies, which recommends delivery of all 8 care processes, and that includes urine albumin creatinine ratio testing. And you have to do all 8, you can't pick and choose. There are also some obesity related indicators. We know that obesity modifies your outcomes, not just for kidney disease. And there's an update on the heart failure indicators, which includes therapies that are also good for kidneys. So there are some changes in the GP contract that might help us do that early detection and management. Next slide. The charities have also mobilised. So this is just Kidney Care UK. The other charities are also doing things, but they've launched a national public awareness campaign. So you may have seen some of these posters on billboards, but it encourages people to do a kidney health check. So just to see if they're at high risk and whether they should be proactively going to their healthcare providers or their pharmacists or to talk about kidney disease. Next slide. So I think we're at a point where early detection is important because now we have therapies that can also change what happens to people down the line. So instead of progressing to kidney disease like we've had for the last decade, maybe we can stop people getting there if we detect them early enough. And this is a great paper that I would encourage you all to read because it really gives us an opportunity to think about what's possible. Next slide. It's a bit of a complicated slide, but what it's showing at the bottom is 2 charts, which in the bubble shows all the different clinical trials. And on the axis, you can see the rate of kidney function decline. And as you can see, over the years, particularly more recently, there's been a lot of studies that have been able to slow down that rate of EGFR decline from 6 mils per minute per year to 1 mil per minute a year, which is normal aging. So that's not just in rare diseases, that's in diabetic kidney disease and rare diseases such as IgA nephropathy. Next slide. So we do have an opportunity to think about absolutely changing the future for people. And this is just a campaign that's been launched in Australia. So we're there, they see that this is a turning point and they are planning to end dialysis by 2050. So there's a challenge out there for the global community to see what they can do. The next slide. So I think to summarise, yes, CKD is a global priority as well as a national priority. There is a link with cardiovascular events, of course, but we can potentially attenuate dialysis and transplants. We have to have better urine ACR and EGFR testing, and there's some now QOF elements to support that, as well as a public awareness campaign. What we'd like to see where the opportunities are, really increasing that urine ACR testing in at-risk groups, so that early piece, but then also ensure that patients are on treatments to prevent progression. It's not just good enough to diagnose, we need to do something about it. So thank you very much, and apologies, I've gone a minute over.
No worries.
I'll hand it back to Laura. Thank you.
Thank you, Smita. So I'm going to spend the next sort of 12-ish minutes talking through the specifics of the CKD programme of work. And I'm going to try and do my best to condense down what's been about a year's worth of work into a 12-minute slot. So bear with me as I try to do that. Maria, if you can just move to the next slide, please. So I'm just going to start with giving an overview of the programme objectives. So when we started this programme, our overarching objective was to design a real-world model of care through a specialist reference group for identifying adults at risk of CKD and optimising the initial management in primary care. We also wanted to enhance CKD service delivery through optimising the workforce and redesigning service pathways and tailoring that to participating PCNs. We had the objective of ensuring sustainability and scalability of the model of care, meaning that it could be applied across multiple PCNs, whilst embedding a data-driven approach to workforce and activity modelling. And then the final objective for this piece of work was to enable us to evaluate and monitor the outcomes. Next slide, please, Maria. So when we started the programme about a year ago, we held a national expression of interest process, and that resulted in the CLEAR team programme, the CLEAR programme partnering with 2 ICSs. So we had Lancashire and South Cumbria and Norfolk and Waveney ICS. And what we did is we brought together those ICSs with clinical and strategic representation from NHSE, and we formed a specialist reference group. And it was that specialist reference group, so our design board, that we're tasked with designing a scalable model of care to reflect that best practice for identifying adults at risk of CKD and optimising their management. And it was that scalable model of care that would go on to act as our blueprint, which could then be adapted at a local level, so at PCN level, to suit sort of local needs and patient population and workforce. Next slide, please, Maria. So Laura alluded to in the introduction the stages of our 4-stage methodology. So with this project, we started in the same way as we always do, and we conducted some clinical engagement. I acknowledge that this slide is very busy, and I don't expect you to take in everything on the slide, but this is just really to highlight the breadth of what we get when we do our clinical engagement. So for this piece of work, we interviewed 25 stakeholders prior to the specialist reference group coming together. And those 25 stakeholders were a combination of clinical and non-clinical staff. We interviewed stakeholders from primary care, from secondary care, from the wider kidney community, so charities, some of our kidney networks. We had some patient voice representatives interviewed. So we had a real sort of broad group of stakeholders. And I think we did around 12 hours of interviews. And so we did some high-level analysis of those interviews, and we looked at some of the key themes coming out of that clinical engagement phase. And those themes were making CKD detection proactive, placing the patient at the centre of the CKD journey, strengthening primary care as the hub for CKD care, bridging gaps in CKD care continuity and integration, and then finally building awareness, education and competency. So that's what came out of what we heard sort of with the various stakeholders that we interviewed. Next slide, please, Maria. So once we'd done that qualitative data analysis, we moved on to looking at some quantitative data. And before we met as a design board, we looked at a few data sets. So we looked at some nationally available data. So we looked at CVD Prevent and what we could see through what was reported in QOF. But we also looked at some sample practice data. So we had 17 practices across 4 PCNs. And we looked at that sample data to try and unpick a little bit more about the CKD cohort. And there were a number of sort of key insights, and I'll draw attention to a few on this slide. So we were aware of the potential prevalence gap between the known CKD patients and then the estimated national prevalence. We could see that there were a high number of uncoded persons, so patients who had biochemical evidence of CKD but hadn't been coded. We could also see that there was a high number of persons on the hypertension register and with known CKD stages 3 to 5 who hadn't had urine ACR tests. So those were things that we found from the nationally available data. And then from our sort of sample data set, towards the bottom of this slide, you can see we looked at some of the utilisation of the CKD cohort. So what we could see from that sample data was that the CKD cohort were using 2.2 more practice appointments per year than those without CKD, but also that that cohort of patients were 2 times more likely to attend ED and 6 times more likely to require an unplanned admission than those without CKD. So when we took what we learned from the qualitative piece, so those qualitative insights and then the quantitative insights, as a specialist reference group, we made some recommendations. So Maria, if you can move to the next slide for me. So we made 11 key recommendations in total. In the interest of time today, I'm just going to highlight a few. So I'm going to start with the one in the middle of the screen, which is the recommendation to streamline with existing long-term condition workflows. And this recommendation was made very much based on what we heard in clinical engagement around the number of appointments CKD patients were having, the fact that there was probably duplication and that these patients were coming in for various long-term conditions and having lots of different appointments spread out across the year, which probably meant there was touch points happening that didn't need to be happening. And so we looked at a recommendation around how we align CKD reviews and management with that of other long-term conditions such as diabetes, hypertension and CVD in a single primary care pathway, in the hope that that would streamline recall, reduce some of that duplication, and then ensure that there were clear sort of referral for advice and guidance to each service. Then in the top left-hand side, we made the recommendation to strengthen case finding and register completeness, again tying in with that, you sort of making detection sort of a bit more proactive. And this recommendation was around how clinical systems are used in addition to population health tools to try and identify those uncoded patients, but also those at-risk cohorts. And a lot of the recommendation here was also around just not the sort of initial coding that is done as well, but some of the reconciliation and making sure that we update some of that coding as that occurs. And then in the top right-hand side, we made the recommendation to build the workforce capability and confidence. And this was very much off the back of what we heard again in clinical engagement, where there was sort of varying confidence and competence levels within primary care around the management of CKD. So this was really in relation to targeting sort of upskilling for GPs, nurses, pharmacists, healthcare assistants, and making sure that that workforce is supported by concise standard operating procedures, decision aids, and medicines optimization guidance. And then the final recommendation I'll draw attention to in this session is the recommendation for a practical cohort-based rollout. And this recommendation was very much made on the basis that it was felt that in primary care, there is an infinite resource. There's definitely not infinite resource to allocate to CKD care, and CKD is always going to compete with other conditions. So the recommendation was made that instead of thinking of the CKD cohort as a total cohort at primary care level and trying to do everything from day one when we implement a new pathway, we actually break that cohort down into sub-cohorts, and then we can sequence improvements in that pathway by phase in the delivery of it. You can move to the next slide. So this is just a slide that shows the what. So this was the pathway that was developed as part of that specialist reference group. And essentially this pathway lays out the patient sort of milestones from the point of entry to the pathway, so where the patients are picked up, and takes through the testing and having the patients reviewed in a long-term condition appointment, how specialist input may be sought if required, and then how monitoring and recall frequency would be managed. And what we did for each of the milestones is we mapped what could and should be done at those various time points, things that could happen within those appointment types, etc. And that just laid out and defined that pathway really well. If you move to the next slide for me, Maria. We also did the same for the undiagnosed patients. Again, that pathway looks very similar with the addition of a diagnosis consultation. And then again, at the end of that pathway, once the patient's been diagnosed, those patients would enter the diagnosed pathway that I showed on the slide before. So that was very much the what, and that was mapped out as our blueprint pathway as an output of that specialist reference group. Next slide, please, Maria. So once we had the pathway developed, we spent quite a lot of time in our design board talking about how that pathway could be delivered. So this is where the kind of phased rollout discussion kind of got into a bit more detail. In the left-hand side at the bottom, you can see that 4-phase rollout. So the first phase was to focus on the recall and optimization of the existing CKD register. So those patients who were known to have stage 3 to 5 CKD. Then we move on to the second phase, which is around diagnosing, coding and initiating treatment for those uncoded patients. So patients with biochemical evidence of CKD 3 to 5, but who hadn't been subsequently coded. And the third phase was around identifying, coding and managing those with early signs of CKD. So those patients with stage 1 to 2 CKD, but in targeted cohorts. And the targeted cohorts were patients with hypertension, patients with heart failure, patients with diabetes, and patients with established CVD. And then the final phase was embedding audit and quality improvement activities within the pathway. And that phase really was to look at the previous phases, whether that pathway was functioning efficiently and effectively, and making sure that no patients within those cohorts were slipping through the net. So we had the what in terms of the pathway, we had the how in terms of how it was to be delivered. And then we moved into the second stage of the programme, which was our CLEAR focus. And this is where the CLEAR team did more focused work with PCNs to look at how we adapt that blueprint pathway to make it fit for purpose where those PCNs were based. And that was based on PCN activity and workforce modelling. So we looked at the cohort numbers for those PCNs. We looked at the appointment utilisation for those PCNs. We looked at testing rates, prescribing rates, all of the various things across those PCNs, and then made adaptations to the pathway as required. And the 5 PCNs we worked with are listed on the right hand side here. So the top 3 were the PCNs who worked with us from Norfolk and Waveney, and then the bottom 2 were the PCNs who worked with us from Lancashire and South Cumbria. Next slide, please, Maria. So as a result of the CLEAR focus piece of work, as I say, each of the PCNs made their adaptations, and there were some variations across all of the PCNs, but most of them stuck very closely to the blueprint because obviously they've been involved in designing that as part of our specialist reference group. So all of the PCNs engaged with all 4 phases of rollout. There were some variations in the workforce. So most of the PCNs opted for a nurse or pharmacy-led pathway, but we did have one PCN that wanted their new patients seen by a GP, and then the existing patients and follow-up patients being more of a nurse-led approach. We had some variation around patient education and support. So in most cases, PCNs were going to opt for signposting patients to publicly available resources, but we did have a couple who either were already delivering group sessions or had aspirations to deliver group education sessions. And then there was some variance around the technological support, with a couple of the PCNs having access to self-service kiosks in the waiting rooms for things like BP monitoring, which meant that the workforce was then a little bit different because there wasn't such a requirement on their healthcare assistants. And next slide, please, Maria. And then the final piece from me is really around some of the potential impact. So we modelled some potential impacts for the 5 PCNs collectively. We did this over 3 categories. So we looked at primary care, secondary care, and patient outcomes. In the interest of time, I'm going to mainly focus on the primary care impacts today, whereby we looked at, through that improved long-term condition pathway efficiency. So if we're going to align sort of CKD reviews and management with that of other long-term conditions, what the impact could be if we made a 20% reduction in the average per patient per year count for appointments. And what that looked like across the 5 PCNs was somewhere in the region of 46,000 appointments. So that's freeing up a number of appointments that could be used for other reasons or with other patients. So a significant potential impact there. We also looked at the impact on secondary care, where we looked at sort of reductions in unplanned admissions, ED attendances, and specialist nephrology outpatient appointments. And then for the patients, we looked at the reduction in cardiovascular events over a 5-year period. So the reduction in MIs and strokes, and some of the potential impacts there were considerable as well. Next slide, please, Maria. So at this point, I'm going to hand over to 2 of the PCNs, the first of which is Breckland Alliance, and we have Yeti joining us. And Yeti, as I said in my introduction, is a lead nurse from the PCN and was the clinical lead for Breckland Alliance. So Yeti is going to give you an overview of her PCN in terms of background, how they kind of found participating in the programme, what some of the challenges were, and then some of the early insights seen, because although they've only just started to implement their new model of care, they are already seeing some good improvements. And then once Yeti has done that for Breckland Alliance, we're going to go over to Mike, who's going to do the same for Garstang. So Yeti, I'll hand over to you.
Thank you very much, and thank you for having me. My name is Yeti, and I'm the lead nurse at Grove Surgery, and we work in the PCN, which has 4 surgeries, 3 in Thetford and 1 in Watson. Can I have the next slide, because I think that tells us a bit more about patients registered. And so for myself to be part of this was amazing. My colleague Joe Loads, who's on this call as well, kind of recommended us for it, and the board was happy to kind of put the paperwork in and make us part of it. And prior to this project, about 2 years before that, we already started working as a group working with CKD. So we made CKD an LTC, so it was already part of our long-term condition planning. In the PCN, myself and my colleague Annabelle Davey, who's our clinical pharmacist, we do all the LTC, so it's easy to kind of get that work going because there's only 2 of us involved in that. We let the GPs kind of out of this process for the moment. So it was kind of good that we already started that work, and what it showed from the program is that actually we weren't doing too bad. And if I look, I just wrote it down, but in 2021 we had 82 people on our registered with CKD. We now have 461. And we're still detecting more people just because of the increased knowledge that we have because of this plan, but as well the learning and teaching we have done with not only ourselves, but the GPs, the receptionists, which play a big part of it. And we are doing group education sessions for our patients with that as well. So that it's trying to focus on everybody and make that patient experience the best that we can make it. Next slide, please. So challenges. There's so many people who were not coded, and we're kind of slowly getting through it. The difficulty with this is because we're a small team at Grove, and all the surgeries like School Lane and Watson, they all work differently than us. It's trying to get everybody on board, which we're trying to do, and we're kind of working together, trying to get the group consultation run as a PCN. This is going to be far in the future because, like I said, we all work differently, but hopefully that will come. A lot of people do come multiple times, and we're looking at how we can reduce those numbers. So if I'm not sure how we code them, and we do the blood tests based on and the ACRs based on the creatinine clearance and things like that, but we're still getting too high numbers really that they attend. So we're looking at how we can reduce that. What we have done since this project is that we weren't asking ACRs for any hypertension patients. So we really put a lot of work in that, and that's working. We're detecting some people. We're getting the codes in. So I'm coding everybody, even if they have CKD 1, 2, 3. So we're building on that, and I think that not only helps us look at progression, for the patient if they're from 1 to 2, 3, but we're research PCN as well. So it helps with the research side of things. So if we do have a CKD study, it's easier to pull the codes and then kind of work on what cohorts that need to be addressed. There's, I think CKD, it's so difficult because we don't get a lot of funding for it, so it's never been a priority. Myself and Annabelle are very, very passionate about it, and I think patients are now starting to recognize, and this is mainly through the group consultations, that they're recognizing how much work we put in, that they're not kind of that obvious before, or were not so, so aware of. So when we ask for a blood test, they're like, oh, another blood test. But now, because of the education sessions, they're starting to understand why we want these blood tests, why we want them on certain medication, why we might need to reduce their medication based on their kidney function. So the feedback was really, really positive in the sense that they were kind of saying, I never knew you cared about us, and people saying we're not alone. I now understand what I need to do. I need to eat, for example, less salt. I need to keep hydrated. I need to lose the weight. I need to keep my blood pressure under control. And I think that is one of the biggest things that have come out of the work that we've been doing for the last 2 years is that understanding of patients, that it's not only us who need to do it, but they have a big role in here, and they need to kind of work on it as well. And with the group consultations, we're trying to get now a CKD2 presentation together so we can catch those early groups and hopefully prevent them to, from progressing to CKD3. But that takes a lot of time in itself because there's only two of us doing it, myself and Annabelle Davey, in the sense of presentation, things like that. We have a GP, and I think that is more to get the numbers in and the people in, because people love GPs and they don't get to see them often. So if there's a GP present, that is a good positive factor. I think one of the challenges that we'll have going forward is, because it's nurse-led and pharmacy-led, that some of our GPs are losing the skills, so they're not up to date. So we'll have to kind of put that training in place and somehow get them back involved in the long-term conditions. Next slide, please. So, like I said, we're getting more people coded as CKD3AB. We're getting more people coded as CKD2. We're using the 5-year risk score. I think the difficulty with that is, even though we kind of code people, and when they're at the 5% or edging towards that, and we make the patients aware, it's then the link to the GPs who often say, well, not much has changed over the last year. They're on the ACE, they might be on the DAPA already. What is renal or nephrology going to do? And that's where we need to kind of put that education in, that a lot can be done. And we need to have that communication with secondary care and the consultants there, just to kind of optimize the kidney function and keep them as good as we can, really. Like it says here on the slide, we are going to put more education in place. At the moment, we're trying to do one group consultation per month, and that is alternating about the importance of statins, pre-diabetes, menopause, CKD3. But like I said, we're going to go CKD2. We're putting one together for obesity and how you can the benefits of losing weight. We're working on a different ones about preparing for pension age and the importance of looking after your health in that. So it's very widespread. After we finish the hypertension cohort with the ACRs, then we're going to try and get more of the heart failure patients. The diabetics, we're doing okay. I think we're doing okay with getting people on statins as well, but it's just getting the other risk groups in as well. But because we're a small team, we just don't have the time to always do it, everything together. So we need to kind of slowly build and then do the next phase and slowly build, which is what this program is all set out to do. So all in all, it's going well. It's a lot of work. It's hard work, but it is really, really good fun. And the patients actually, they're so happy, to see that you're putting that effort in. And I think that's the biggest reward for myself as a nurse is that they're understanding it more, and it shows that we are caring towards them, which sometimes they lose a little bit when they can't see a GP or they can't get the appointment they want. This kind of shows that we are caring, we are doing a lot of work, and that they're at the center of it, really. Next slide. Oh, well, there you go. Mike, I'll hand over to you.
Cheers, thanks for that. So my name is Mike Oliver. I'm a GP in Garstang in Lancashire. I'm also got a specialist interest in nephrology, so I'm coming from a bit of both camps. So I work for the local trust with Beng So, who's one of the other speakers. So I would do a general neph clinic, which I've been doing for about 15 years now. So kind of a foot in both camps. But thinking of things from primary care point of view, we're a slightly different setup in that we're a single practice PCN. So we were part of a 5-practice PCN, and then we kind of went solo, a bit due to geography issues and the fact that the other practices were kind of like considerable distance away, so linked up working was difficult. So we've been only going solo since last April. So we've had a year of being a single practice PCN. Next slide, please. So 21,000 patients. I think I'm going to start with the key take-home messages, because the thing about renal medicine is it's not very often new things come along. So, obviously we've got the SGLT2s. So once every 20 years, maybe twice in our careers, you might hear something new coming along in nephrology terms. So I think the key messages are that we have to do the simple things very well. And that's basically where this project comes into its own, really, because it's about identifying areas where we can improve, but it's not reinventing the wheel by any means. It's doing the simple things but very, very well, and that's what's going to save these patients from progressing to end-stage kidney disease. So in our practice, we're a big practice, we're a merged practice, so two practices have joined together to make one, and so we've got a well-established team of chronic disease nurses and pharmacists and advanced nurse practitioners, but that has its own difficulties in that you can kind of get a bit lost in the system, and I think that's where we were going wrong, really. We were kind of not linking up all our different elements of long-term conditions. So next slide, please. So we noted we've done quite a lot of work in terms of list cleansing our patients already, working closely with Lancashire Teaching Hospitals and running the CDRC searches. So we already had a good idea that we could already have the information at hand in terms of those numbers of patients who were probably not coded appropriately. So those patients with abnormal GFRs that weren't coded as CKD. And also those patients who were coded but hadn't been sort of optimized in their treatment. So we already had that data at hand, but we had trouble joining the dots in terms of how to use that data to improve sort of the patient journey, as it were. We noted that quite a lot of patients with CKD are high users of primary care appointments. So, for example, some patients were having up to 25 appointments per year, and the common denominator, so the average number of appointments per year is around 7 per patient, but that's including newborn babies and 100-year-old people. So the average number of appointments is extremely high for patients with CKD. Some patients having 25 appointments per year. So that's obviously a big strain on any system. So the idea behind our project really is to try and streamline the work that we're doing already, but to sort of improve it essentially. Next slide, please. So the idea was to kind of take the system we have in terms of our CDM management, but try to, bring in CKD as a everyday business as usual idea, making sure that we're essentially coding all the patients appropriately, getting all the patients with CKD on SGLT2, ACE inhibitors, the basic well. But the way we did it was essentially by incorporating CKD into the long-term condition pathway. So obviously looking at QOF, and we have our own local, what they call quality contract from the ICB. They're basically focusing our minds on other areas, so COPD, diabetes, hypertension, when really the common denominator of all these at-risk groups is often CKD, without saying CKD out loud. So it's that idea of bringing in patients with CKD into the long-term condition pathway through education, upskilling of the current staff cohorts. And I think another key message is that you don't want to be seen to bring in extra workload into your primary care teams, because we're already at bursting points within primary care, and simply introducing extra levels of work doesn't help. So it's the idea that you're taking the existing work but improving it for everybody. Next slide, please. Okay, so essentially what we've done in the practice is we've taken the current long-term conditions pathway, we've implemented CKD into that. At present, we've got 5 prescribing pharmacists who are basically, we're utilising their skills to titrate, do the titration phase of of the scheme for us. So patients will be seen by there'll be a doctor who's kind of overseeing things, but essentially the service is pharmacy and long-term condition nurse led. So our patients will be seen by the long-term condition nurse as part of their annual review, but CKD is incorporated, so they'll be seen for the diabetes element, the hypertension element, and then the CKD elements, all in sort of a one-stop shop, as it were. Those patients will be identified that require up titration, so whether they need up titration of their ACE or they need introduction of SGLT2, they'll kind of go onto a titration pathway, which is run by our chronic disease pharmacists, who will kind of take the patient under their wing into the titration phase. That might involve a face-to-face consult or several phone calls, and then when the patient has been optimized, as it were, they're kind of popped back into the system for an annual review or any interim reviews that are required. And then GP will get involved if there is any more complex patients where there's a stumbling block along the way, where they're not tolerating the treatment, or they might require a sort of more a physician overview, or whether the patient might need a referral onto secondary care. So I think the team has sort of taken it really well. We've had quite a few in-house sessions. We've got another one today, actually, at practice closure afternoon, where we'll sort of either discuss particular difficult cases, or we'll use the sessions to discuss any stumbling blocks that have been noted along the way. So I think it's really just driving home the idea that we should do the simple things well, which is the key thing of kidney medicine. Trying to make sure our non-doctor colleagues are not too afraid of kidney medicine, because it does have a bit of a there is a long history of people worrying about CKD as being something really complicated, and that idea that it's like a team approach. Thanks.
Okay, thanks, Mike. I think I take over from Mike before Shanika kind of rounds this off. So, Laura, could I have the next slide, please? I'm Ben, so I'm a nephrologist at Lancs Teaching Hospital and clinical director as well. Our patch covers quite a large proportion of the Northwest, with about 1.8 million population. So just the first of my few slides kind of reinforces the message that Smita gave earlier. These are just a few little excerpts from a summary of the Kidney Research UK report, which highlights the burden of kidney disease, and Smita pointed out the international burden. So maybe starting at the bottom right, at the moment it's the 10th biggest killer. In the next 15 years, it may be the 5th biggest killer, which is a real stark statistic. Now, the vast majority of these people won't die of renal failure per se. It's a cardiovascular disease. They will die because they'll have heart attacks and strokes. Again, I'm laboring a point already well made by Smita. We're seeing numbers of patients increasing, and they also have overlapping health issues. And we've heard several GPs and the CLEAR program look at the efficiencies that could be gained from streamlining these processes. And that's one of the kind of crucial findings from this, which is amazing. At the moment, or actually this is quite old data, maybe about 10 years old, about 3.2% of the NHS budget, up to around £7 billion, is taken up by kidney care. And a significant proportion, but not the biggest slice of the pie, is dialysis, because it's incredibly expensive. Not just for the delivery of dialysis, but also to the individual patient. It is, been variously described to me by patients as a part-time job you didn't want to have, you don't get paid for, and you can never get a holiday from. So for a lot of these patients, if you can get them transplanted, that's amazing. Transplants are still expensive as well, and it's something that we always strive to do. Next page, please. Next slide, please, Laura. So bear in mind, I said renal disease takes up about £7 billion of the NHS budget. There's only a handful of nephrologists in the UK. about 674 when the statistics were last released in 2021. So that's fewer than members of parliament. So unfortunately, not every nephrologist is getting paid £10 million a year. A lot of the budget is on kidney disease is from hospital admissions, unplanned care, renal failure. CKD patients have longer, almost twice the amount of hospital bed days, not just more admissions. And it's a key structural issue. There's fewer nephrologists in the UK than there are, for example, Italy, Germany, Spain. These countries have kidney doctors that only do dialysis, kidney doctors that only do glomerulonephritis, kidney doctors that only do CKD, whilst kidney doctors in the UK tend to have to be, do a bit of everything. Next slide, please, Laura. And this slide here is really just to show that kidney doctors deal with the most advanced CKD patients. So as the CKD gets more advanced, they're more likely to fall into a specialist clinic, up to patients who are on dialysis or transplantation, have far more, I think it's fair to say, appointments with a nephrologist than they do any other healthcare provider. But if you look at the right-sided graph here, in a typical GP practice, over 95% of the CKD patients are CKD stage 3. So they're mild. They may never see somebody like Smita or myself or Gavin, and a lot of that care, so a lot of that opportunity to prevent worsening of renal function or reducing the cardiovascular risk sits in primary care and in a lot of the work that have been highlighted by our primary care colleagues on this talk today. So that's where a lot of the efficiency gains from improving the pathway to free up time to make CKD registers more accurate and ensure the right treatments, new treatments, well, say SGLT2 is new, but it's actually been around for 15, 20 years, the right treatments for the patients so that, maybe in 2050, Australia, UK can be like Australia and have no patients on dialysis. It's laudable, but I think Smita and myself will still be in a job. Well, hopefully we'll be retired by then. But anyway, so next slide, please, Laura. So really, potential impacts of the work. Now, although it says things like reduction are qualified, so reduction in referrals because there's more confidence in managing primary CKD, less progression, that'd be nice. Reduce ED attendance because less heart attacks, less hospital admissions, improving, and this can be done through a lot of the work that's been shown here. In effect, it's not going to be reduction because we know there's a demographic boom of the one called baby boomers, but people born in the 30s and 40s. And that is going to increase the demand. So if this works well, if anything, will be wait times won't get worse rather than me sitting thinking, "Ooh, it's quiet clinic today." So these are the kind of benefits that we all hope will benefit the whole system and patients in the end. Thank you.
Thank you. I think it's over to me now. Can everybody hear me?
Yeah, we can.
Perfect. Thank you so much. I am mindful of time, but we've got a couple of questions to go through. And as Laura mentioned earlier, if you do have any questions for us after this, please do get in touch and we are happy to answer them for you. Thank you. So the first question I have is for Yeti, actually, on sustainability focus. So a key objective of the programme was to create a sustainable model of care. Can you talk a little bit about what key enablers did you identify through the CLEAR programme to support this becoming business as usual, Yeti?
I think it is already business as usual because before we started with CLEAR, we were already managing CKD as our long-term condition. We made it a long-term condition. So whether they only had CKD or if they had heart failure, diabetes. So it was already part of that. I think looking forward, the difficulty is when I retire, because they need more nurses. In my practice, I'm the only nurse doing any long-term condition, and the pharmacist and I are bound to retire in 10 years, but both at the same time. So what we are trying to do, and I don't know if that will ever happen, is set up an PCN long-term condition service where we build our nurses up. So if you, for example, only do asthma, you see all the asthma patients for the PCN. If you do asthma and COPD, you see those, and the more conditions people have, the more skilled the nurses are. But you kind of train up your workforce as you go, so people get the experience. Like I said, whether the idea is there, we want to run with it, but it's all about money and willingness from the 3 PCNs to work together and finding a good accommodation to kind of do that service. But for the moment, I think we're doing well. It's part of what we're doing. It's working well. We're getting better at what we do. It's like Mike said, doing the simple things well. There's still a lot of work to do. Definitely getting people on the SGLT2s. We need to improve on, but it's happening slowly but surely.
Thank you. Both you and Ben have mentioned retirements. I think we need to add that on the agenda for the next discussion. And very quickly as well, for our next question, it's over to Mike. So patient benefits with a CKD focus. So what would you say, Mike, are the key benefits of your model of care for patients with CKD? And how would their experience differ as a result of your PCN's participation in the CLEAR programme?
I think it's patients don't like it if you call them into the practice loads of times for things to be done to them. So although we all know, like as clinicians, the science behind why we're doing what we do, a bit like my colleague said earlier, Yeti said about patients want to know why they're having the test done. So I think that it's all about reducing the patient's miles traveled, as they say, isn't it? So if you make sure you're getting the most out of any interaction you have with the patient. So if you call them in for the hypertension review, call them back for a diabetes review, call them back for a COPD review, patients start not engaging. So I think this project has made us streamline our processes so that you're actually reducing the number of contacts you need with the patient, and then making sure that each contact you do have with the patient really counts and that you're getting the most done that you can in that interaction. So that's definitely been a positive for our patients.
Okay, thank you so much, Mike. I'm going to hand back to Laura. We are 1:30 on the nose.
I'm just going to pick up on one question in the chat, because I think we've been asked this as we've been working through the programme, and I think it's a really valid question for me to answer whilst we've got people on the call and mindful of time, and we'll try and do it very quickly. So Swati's asked the question around how would a programme like this work if there aren't key staff who are already having that insight or passionate about CKD or multiple long-term conditions. And I think it is a really good question, and I think we have been challenged on it in the work we do here and the work we've done in CVD. And I think there is more of a challenge when that's the case. So when PCNs or practices that we're working with come in at a slightly different starting point, where they're not so mature in sort of managing, for example, CKD, or they come in at a sort of starting point where they're not all sort of already engaged, or they don't have a workforce dedicated to this. And I think what the programme helps us do is look at what their starting point is, look at what it would take to be able to deliver the pathway that is the aspiration, for us to work on a workforce model with them, and then to set them up for success by working on that kind of case for change or a business case, that if investment is needed to get them off the ground and to be able to deliver that, then part of our approach with CLEAR is to sort of leave our colleagues with that, so that they are set up to enable them to be able to put something forward for that investment, but also show what the potential impact of that investment would be. So hopefully that's helpful, Swati, to answer that question. And I'm aware of time, so we are going to try and wrap up because we are over time now. But I wanted to say thank you to everybody for the contribution today, particularly our speakers, for sharing their insights and experience on this piece of work. I personally really enjoyed delivering this programme, and have met some wonderful colleagues along the way who I know that I will stay in touch with and probably work with again in future. We hope that everybody who's joined has found today's webinar useful. If you do want more information about CLIA in general or this piece of work, our details are on the screen, but I'm happy for people to contact me directly, and we're happy to shout about this work wherever we can. So if anybody wants to learn more about it, please get in touch with us, and hopefully you've taken something valuable away from today as well. But thank you so much, and we hope you all have a nice day.